Welcome to Oral Premalignant Lesions, a Diagnostic Atlas. This video provides clinical and histopathological frameworks for leukoplakia, erythroplakia, lichen planus, and submucous fibrosis. The malignant potential of these lesions varies. Erythroplakia has the highest risk, around 90%, demanding the highest clinical suspicion. Malignant potential is directly correlated with epithelial dysplasia, making erythematous lesions critical. Leukoplakia presents as a fixed, non-scrapable white plaque with a firm, leathery texture and abrupt margins. It predominantly affects males over 30 and is associated with tobacco, alcohol, and betel quid use. Chronic irritants like tobacco or betel nut cause mucosal injury, leading to hyperkeratosis, which forms the white plaque. This can progress through clonal expansion and p53 mutation to epithelial dysplasia and eventual squamous cell carcinoma. Erythroplakia appears as a fiery red, velvety patch with alarming malignant potential. It presents with sharply demarcated borders, lacks a white keratin surface, and is extremely rare compared to leukoplakia. It is highly dangerous, so do not watch and wait. In erythroplakia, epithelial atrophy exposes underlying blood vessels, causing the red appearance. Leukoplakia's thick keratin masks these vessels, making it white. Critically, 90% of true erythroplakia cases show severe epithelial dysplasia or carcinoma in situ. Oral lichen planus features bilateral lacy white striae, known as Wickham's striae, and often painful erythematous erosions or central ulceration. It shows a female predominance and is often bilateral on the buccal mucosa. Oral lichen planus is a type 4 hypersensitivity reaction. CD8 plus T cells attack basal keratinocytes, causing liquefactive degeneration. Histologically, this results in sawtooth rete ridges and a dense, band-like lymphocytic infiltrate. Oral submucous fibrosis, or OSF, creates a rigid, blanched, marble-like mouth with severe trismus. Clinical hallmarks include blanched mucosa, palpable vertical fibrous bands, loss of elasticity, and is primarily triggered by chronic betel nut chewing. Areca nut alkaloids biochemically force irreversible collagen cross-linking. This involves upregulating TGF-beta and lysyl oxidase, leading to massive fibroblast proliferation. The outcome is dense collagen bundles, mucosal ischemia, and trismus, with a 10 to 15% dysplasia risk. The rule-out algorithm helps isolate premalignant lesions by clinical exclusion. For white patches, if it doesn't scrape off and other conditions are excluded, the diagnosis is leukoplakia, requiring a biopsy. For red patches, if local irritation is ruled out, erythroplakia is diagnosed, requiring an immediate biopsy. This matrix summarizes key differentiators. Note the distinction between leukoplakia's hyperkeratosis and non-scrapable nature versus erythroplakia's severe atrophy and high risk. Oral lichen planus features lacy lines and an autoimmune trigger. Submucous fibrosis is defined by hyalinized collagen and trismus. The standardized clinical workup begins with visual examination and measurement. Next, eliminate irritants for 2 weeks. Adjunct screening with toluidine blue can highlight dysplastic areas. The gold standard is a definitive tissue biopsy. Remember to always biopsy erythroplakia immediately. Treatment is targeted based on biopsy results. These high-yield mnemonics aid rapid clinical recall. Cancer covers leukoplakia features. Red reminds us of erythroplakia's red patch, atrophic epithelium, and high dysplasia. Planus details lichen planus, and betel describes submucous fibrosis due to areca nut. The golden rules are essential. Leukoplakia is a diagnosis of exclusion. Erythroplakia is carcinoma in situ until proven otherwise and requires immediate biopsy. Symmetry suggests systemic immune processes, and trismus points to areca toxicity leading to submucous fibrosis.